Good evening, everyone. Welcome to the Ace the Clinical MRCPCH evening from the London School of Paediatrics. We are, myself and Josh are part of the London School of Paediatrics Trainees Committee. I am Katie. I am an ST5 in London, but currently lurking in Edinburgh. And Josh, would you like to introduce yourself?
Good evening, guys. Yeah, I'm Josh. I'm also on an OOP just now, actually, and still based in North Central and East London, though, for the time being.
The usual housekeeping in terms of if you can turn your video on, it's nice to see faces, but don't worry if not. We are recording and this will go on the London School of Paediatrics YouTube channel. If you have questions, either stick them in the chat or stick your hand up and we will do our best to answer them. All of the information that we have is from a combination of the RCPCH website, our own experience sitting the exam. We both sat it in the face-to-face format, but I also sat the pilot virtual format one. We have both, I was and Josh is part of the RCPCH trainees committee as well, so we have experience within the exam but don't know anything that no one else knows. So if you have any questions that we can't answer, I would suggest you go to the RCPCH website, which is wonderful, and they have lots of people on their emails that can answer questions too. Let's get going. So I will just go through the sort of the objectives of the exam. So the aim of the exam is to check that you are the standard of a newly appointed ST4. You are not supposed to know everything. You are supposed to be a baby reg. And the things that it will look at is communication, history taking and management planning, establishing rapport with parents and children, physical examination, child development, clinical judgment, organisation of your thoughts and actions, recognition of acute illness, knowledge of paediatrics and child health, professional behaviour and ethical practice. These are all of the things, it sounds like a lot, but it's also all of the things that you do every day, so you can do it. If you did happen to sit the exam previously or started revising pre-COVID, lots of the stuff is the same. The children are not changed, but some of the stations have changed structure, and we'll talk about them a little bit as we go along, just in case. The main ones that have changed are obviously the clinical stations and the development station, because there won't be children, and the process of examining is very different. But the communication, history taking and video stations are pretty much unchanged as the virtual exam. This is the website in particular that is very useful. I'll stick it in the chat in a bit. We will send it out with all of the details. Basically, it's the RCPCH page and they update it every time that something changes. In the first start of COVID, obviously things were changing quickly, but as things change, particularly for overseas candidates, the process is changing, so they will put it there. There is a webinar up there that they have recorded fairly early on, and information from other samples, like how the video structure, like how the system works. There's a usual backlog of trainees trying to sit the exam, particularly since there was a few that were completely cancelled at the start. So they're trying to increase the numbers, but it's the same criteria for allocation and same reasonable adjustments are possible. They suggest you don't sit the exam at work, partly because NHSIT is the worst. And Pratique OSCE is the system that you use, and it would not cope well with poor internet. There are ways that you can test it before the day so that you can make sure that you can get into the system, and then you just need to make sure you're not interrupted. Every station has an invigilator to make sure everyone is in the right place, so it does feel a little bit like there's even more people watching you, but you just have to, they're only there to make sure that everyone gets into the right station and leaves the right station. And remember to think about what equipment you need, because obviously one of the useful things when you're going into an actual room with a child is if there's, you know, an ophthalmoscope on the side, maybe you need to use it, but you also have to think about those things now a little bit more. You still have to verbalise your permission to examine, saying that you're adapting to needs. So, you know, you would make sure that they were happy and sitting on their mum if necessary or whatever. There are definitely a higher chance of technical difficulties now that it's online, but the aim is that these stations are, if there's something does go completely wrong, your internet drops out, or your examiner's internet drops out, they arrange for you to resit it at the end of that exam period, or at a later date if necessary. This is the circuit that they now propose. You have 9 stations, and you do it in sort of 2 halves for the 23-minute stations and the 9-minute stations, and we'll go through all of them individually. There's also an extra examiner who sometimes rotates around to examine the other examiners, not examining you, just to keep them all up to date as well. This is a sort of comparison of the pre-COVID and adapted clinical exams. So the number of stations has dropped slightly, but the total available marks then has dropped, and the pass mark has risen slightly, based on sort of, they did lots of statistical tests on the first few rounds to find the new pass mark. And the things that are different, particularly at the clinical station, you have 2 short and 1 extended. And basically it covers a lot the same domains, but in a slightly different way. And I'll show you some other ways of seeing that to make it clearer. It's 168 minutes. Every station has 4 minutes of reading and 1 minute of introduction, which allows you to get in and out of the different stations. So it feels like a long time, but also once you're in, it's suddenly the end. The clinical domains, so previously each station was marked separately, and you so you could have a station that you failed and stations that you passed, whereas it's now marking by clinical domain, so across the different areas. It's supposed to make it fairer. So if one station goes really wrong for whatever reason, you still pick up whatever points in different domains, and that's where you reach your pass mark. And these are the core skills that you all have, and you just need to demonstrate them in the different stations. And it also aims to make the feedback that you get more focused and useful. So more than just good or didn't hear a murmur, they would be giving, based on the anchor statements, about what it was that didn't quite happen in this exam. So there's a lot of words here, so I'm not going to make you read them. All of this is from the RCPCH website, so it's all there available if you wish to read through it. And this is just a different way of showing how the different domains are in the different stations. So some domains are across more stations than others, as you would guess. So not every domain is tested in every station, and you get domain marks of 0, 1 or 2, with the total marks of 78. There's also the professional conduct domain, which doesn't count the mark, but would be discussed. But you would have to do something quite significant for you to fail based on that. And then if the examiner marks below standard or borderline, they would have to explain why based on those domain markings. For some people who like to be strategic in their revision, this is the sort of percentage of the total points available for each station and for each domain. But I mean, you just have to learn all the things really, but you know, just in case it's useful for you. So now on to the clinical stations. I believe this is me, Josh. I can't remember. Yes, wonderful. So the clinical stations. So the aim is to assess that the candidate can undertake a structured and systematic clinical assessment and identify clinical features. You do this every day. It's the standard of a newly appointed ST4. I'm going to keep reminding you of that. You don't need to be a specialist cardiology something consultant. You just need to be able to look at a child. And there's now 2 different types of clinical stations. So the first is the extended. So this is the most like real life of the different stations. So 10 minutes of history taking 2 minutes of discussion, and then 8 minutes of examination and 3 minutes of discussion. So you take your history, then you decide the examination based on the history that you need to perform, and then you perform that examination. It makes sense. There's also the short clinical, which is more similar to the previous exams. So a 6-minute examination with a 3-minute discussion, and the examiner tells you which exam to perform. It can be any kind of system or case. They say these are the areas that they say could be covered, but this is basically everything. So it could be everything. There's no real patients anymore. So there will be videos, descriptions of examinations, and role players in the extended clinical for the history taking part, but not for the short clinical stations. It's all through the cues and things that we'll talk about in a sec. These role players could be children, so they could be teenagers, or they could be the parents of younger children. So what you have to do is talk through your examination and then be given the findings. So there's 2 things that they talk about. So there's dependent cues and universal cues. And what you need to do is work out how you can describe the examination that you're performing in a structured way. And this does not come naturally. It is something you just need to practice. How to say, like, I would look at the muscle bulk and compare both sides to see if there was any wasting. And then you need to take breath and pause to allow the cues to then be given to you. The dependent cues are the ones that they will only say after you have stated what your examination is looking for. So you say, I would test the lower limb reflexes with a tenton hammer. Pause. They say the reflexes are brisk on the left. If you, when you're practicing, remember to practice taking those breaths after each thing that you're saying, because otherwise they will need to interrupt you to give you those cues, so it might put you off. So just be prepared for that. There's also universal cues. So these are the things that are given at the start of the station and things that you would see as you went into the room. So a scar, a missing limb, a loud wheeze on every breath. And there will be photos and audio and video recordings that you can watch during that initial readings time. You can also go back to them during the station, but practically it's a bit more challenging time-wise. The sort of silver lining to the virtual system is that some of the dependent cues that involve media, you also see at the beginning, because they can't only provide a murmur. When you say that you're listening to the murmur, actually they have to put the murmur at the beginning, and so you can use that to your benefit in terms of trying to tailor your examination description. Yeah, fab. So what's expected? So an organised approach, clear, systematic, sound like you've done it before, competent at assessing the areas and identify the signs present, and then discuss the findings and interpretation at a level of a new ST4. Practice your presentation. This is less so now that it's virtual and you have to do all of you have to present your examination as well, but the presentation, how you perform is where they will give you the mark. So even if you know the answer, if you can't articulate it clearly, then you won't come across as well. So start with your main findings, positive and negative, list your differentials, and as you're working your way through the exam, you'll be thinking what questions are going to come up, and you can start preparing for that. This document is on the RCPCH website, and it basically tells you how they want you to examine every station. So look at it. Development station. Josh.
Thanks, Katie. Katie, just so I don't forget, I'm not able to post in the chat just now. It's saying you can't send messages because you are not a member of the chat. I haven't come across that before. Do you know how to solve that one? And also, if anyone else is having the same thing, maybe raise your hand and we'll see if we can solve it.
Or if you have any questions for now, raise your hand and I will have a fiddle and work out what I've done, because it was working earlier.
It might just be me. It might just be me.
No, mine says it too.
Okay, we'll see. I'll leave you ferreting away in the background on that, Katie. Although actually I need help changing the slides still there. You're a multitasker. Please do let us know if you've got any questions, guys. You can always unmute and butt in any time if you're worried you're going to forget, or jot them down on a piece of paper or something until we've figured that out. Okie doke, so the development station. This is something that's clearly a little different in the virtual realm. The principles and the aim, of course, they are still very much the same. So the RCPCH state the aim as being to examine the candidate's ability to assess key areas of development, key areas being important. Taking a focused history, the word focus there comes up again and again in a few stations we'll look at, and that's very important. Explore reasons for these findings, including the impact on the child and the family. And that last phrase there is also very important, as clearly a relatively social focus station, and that's not all that unusual for a lot of the stations. The history and communication ones, they'll be bringing in social elements quite frequently, so always be prepared for that, and leave time, especially in the history station, there'll often be a social element, so don't just think that you can rush through that last bit of your history in the last 30 seconds. We'll come to the history station in more detail a bit later, of course, though. So the development station, you'll be expected to gather information from the parents and the carer or the child, or any combination thereof. You'll be performing a focused developmental assessment of the child. You'll be using appropriate toys and other pieces of equipment, and then you'll be having a discussion with the examiner on the findings and the plan. As ever, the standard is of a newly appointed ST4. A lot of people are very intimidated by the development station. I know I was. Having not done any community, don't feel too disadvantaged by that by any means. It's far from essential. You can certainly learn what you need to know in a relatively short period of time in a focused way, and we'll give some tips and some resources to help with that. Another important point there in blue is that children used in the station should have a developmental age of less than 5 years. So theoretically, their chronological age could be more than 5 years, but their developmental age and the assessment that you'll be doing will be for developmental milestones at no more than 5 years. So it's not getting into that realm of psychoeducation. It's not about that at all. Next slide, whenever you're ready, Katie. So for the developmental assessment, you have two aspects. You have the history taking, that's 10 minutes history and then 2 minutes of discussion. And then you'll be assessing a specific area of the child's development. And importantly, there's not enough time to carry out a full developmental assessment. They'll specify what they want, which area you're going to be focusing on. Usually that will be a single developmental domain, such as fine motor and vision, for example. Occasionally it might cross into two if it's relatively simple, or if, for example, the child has a very low developmental age and it might be quite quick to progress through two of them, for example. I think the party line these days is that it will essentially never be more than 2 domains, and usually just one that you're expected to assess in a single scenario, a single station. Here they provide some examples of the degree of accuracy you're expected to reach. So for a developmental age of up to 2 years, you can be expected to guess their developmental age within about 3 months, or work it out, I perhaps should say. And between 2 and 5 years developmental age, you'd be expected to work it out to about 6 months. So some reasonable ballparks there, relatively achievable. A little comment about syndromes, and general examination points. The children may or may not have a syndrome or a neurological abnormality. This may be something that's less apparent virtually anyway than when the exam was face-to-face, but may still be something notable. Importantly, your job is to assess the development. Don't get distracted too much by dysmorphic features or other obvious symptoms or signs. Definitely worth commenting on them, but if you do so, do it very briefly. And it's only really worth commenting on them if you feel they're likely to be very they're likely to be very relevant to the developmental assessment that you're performing. But yes, if they have notable dysmorphic features of trisomy 21, for example, then it would be very relevant to make a brief comment, but nothing more than that. And within your discussion, both within the history aspect and the assessment aspect, you'll be talking about findings as well as suggesting a bit of a management plan. That will of course fall more at the end once you've conducted your physical examination. Next slide whenever you're ready, Katie. Thanks so much. So you have various items available. This is a photo of the toolkit, again provided by MRCPCH, as is everything we're showing you. So these are the pieces of equipment that you have available in your arsenal that you can suggest that you would use. So it's a completely standardized thing. You definitely don't have to use all of these, of course, in every station, and probably most of the time you won't be using very many of them in a single station. But you're not really allowed to be suggesting anything that's not depicted here that you would use, just to create a fairly simple and level playing field for everyone. The ones that you're probably going to use most commonly will be things like the blocks, perhaps the simple toys when it comes to speech. The book's going to be very helpful. Crayons are going to be very helpful. Some you might feel you use more than others, but it doesn't matter. You do whatever works for you. Question from Bryony, I think I'll come to in a second, Bryony. Next slide whenever you're ready, Katie. So the developmental history, focusing on this aspect of it, we've touched on already. The idea of it is that you're exploring a likely etiology, and so your history needs to be quite focused, of course. So with regards to teasing out the likely etiology of any developmental impairment, you want to be asking things around the perinatal history, whether they were born early or not, any particular issues when they were born, do they have any known diagnoses of particular syndromes, for example. In their past medical history, is there anything particularly notable? Any infections, any malignancies, any trauma? And a family history of developmental delay and learning difficulties. So you can see already that it's a fairly standardized approach to any history that you would have, but it's importantly very, very focused towards development. You may want to explore whether there are delays in any other domains, but again, just be careful you don't spend too much time there if you have been asked by the examiner to focus on a particular domain. And whether there are any associated comorbidities, ADHD, epilepsy, autism, sort of tying into the past medical history. Really, really importantly, you want to have a bit of an exploration of how these difficulties are impacting the family. And what support do they already have? What social support do they have? What financial support? What educational support do they have? Do they have an education healthcare plan already in place? What school do they attend? Is that working? And what other professionals from the MDT are involved in the child's care already? So it needs to be relatively holistic while still being focused on the development. Practical tips, practice, really important. This is probably something that most of us don't have very much exposure to before we get out there and do the exam. So it's definitely not one to be neglected. It can be a little bit intimidating to go out there and practice this, but my advice would be to start reasonably early and just get cracking on. It's not too bad once you get stuck into it. And the earlier you do it, the more comfortable you'll get. As ever, if you are given any generic prompts about things that are around the room or general things in observation, then do feel free to comment on them and use them, but don't get too distracted. And the general approach to the developmental assessment is, of course, starting with easy tasks, but they should be appropriate ones. So you don't need to start right at the beginning, something that might be a developmental milestone of 3 months, for example. Start with something that's on the easier side for where you suspect the child's likely to be, but doesn't have to be right at the beginning. And then you can move up harder to gradually harder ones or more advanced developmental milestones until you hit the limit and the child can go no further. We suggest that it's a little bit it's worth being careful with your terminology and being a little bit careful about how you word what the child was able to achieve, and suggesting that something like today they weren't able to demonstrate this particular skill or developmental milestone might be a kinder and more appropriate way of phrasing something, rather than just simply stating that they can't do it, because that's probably not accurate. And clearly this is a snapshot. A whole formal developmental assessment in a community setting is clearly very different and far more prolonged. This is really, really helpful. This is available there on the website. You can see in small text just down at the bottom of the page there, mrcpch.pediatrics.co.uk. Really, really helpful resource. I used this and essentially nothing else. So you can see there how it just simplifies the key developmental milestones and other 4 domains, and has really the level of detail that you need to know. I think this is perfectly sufficient. If you come across other things that you want to add in there because you find them helpful, for example, then you could certainly do that. But this is the level of detail that you can be expected to know, and is a perfectly valid reference for you to use for your exam. So we won't spend time going through it, of course, but that resource is out there for you to be using and practicing with. And one other comment on that, I suppose, that's worth saying is you will find various developmental resources potentially that might provide different milestones for the same, so different ages for the same developmental milestone, just slightly, of course, but that doesn't matter. It's accepted that there is a degree of variability between different resources. Just choose one and stick with it. History Station also need Katie? Perfect. So the History Station, a lot of overlap and a lot of similarities here, which is you'll see the common themes, but worth teasing them out every time because they are important. The standard there is, as ever, of a newly appointed ST4. You see a lot of the same keywords. Take a focused history. You're needed to summarize, identify key issues, prioritize, and formulate a management plan. These are all of the aims of this station. The types of scenario you might encounter are either going to be a new problem, given some examples there, new onset seizures, new headaches, new joint pains, or quite commonly it will be a specific, perhaps new problem in a child with an already established diagnosis or an already established longer term problem. So for example, a known diabetic child who's now presenting with weight loss, or a child who's known to have cerebral palsy and then now presenting with feeding issues. No examination, of course, expected in the History Station, just history taking. You may be given extra supplementary information, growth charts, or even test results. So don't be perturbed by that if that does happen. What's expected? There's nothing surprising here. Being nice, that's important. That goes quite a long way, doesn't it? I think that's very true for the whole exam, actually. It sounds a bit silly, doesn't it? But it does just make a huge difference if you be your usual nice and friendly selves, which you all invariably will be. Do your best to relate to the parent, carer, and young person, and if there are multiple people there, of course, do what you would do usually and try and engage all of them in the consultation. A little bit more challenging, of course, virtually, and the examiners do appreciate that. So don't be too perturbed. They're prepared that things are different. They know that, and they are accommodating of that, but still do what you can to establish the rapport. Again, the history needs to be super focused, accurate. You need to gather enough information to determine the problem. What can be a reasonably effective way of doing this, I think, in an exam setting is sort of running through your structure of history of presenting complaint, past medical history, etc., and moving through reasonably quickly, and then having then you could view it as returning to a history of presenting complaint if you have time left over at the end, or you could categorize it as a systems review, however you chose to do it in your own mind. But that might be quite an effective way of ensuring that you tease out the most important things early on, and don't miss anything, and then any extra things you can do with the time that you have left at the end. Basic stuff, questions need to be clear, start with open ones, move to closed ones, don't use jargon. As we've mentioned, you still do need to include all of the other things, and certainly don't forget psychosocial issues. They quite often will be there, and quite often there will be quite a lot to talk about. Immunizations, allergies, all of these basic things, don't forget them, do include them. Previous treatments, medicines, if that seems very relevant, you might have to ask a little bit more about that, how well they're adhering to the medicines, are they having any side effects? And this is really helpful, isn't it? We forget this, but after it was drilled into us at med school, but it's still really helpful. Exploring concerns, fears, expectations, feelings. I was always taught it at ideas, concerns, and expectations. That's really helpful, especially if it's you can ask it early on, but you could also ask it towards the end. And if you do that, often if you haven't teased important things out already, the actor will gift you something that you may have missed. So definitely worth not forgetting to do that. So when you're having your discussions, respond and clarify anything, or that's referring to conversations with the actors, but also when it comes to conversations with the examiner as well. And you can also clarify anything the examiner is asking you. That's really worth commenting. That's throughout the whole examination. If they ever ask you to do anything or ask you a question and you're not quite sure what they mean, please do ask them to clarify. It's completely accepted that people will do that. Be empathetic, be nice, verify and summarize the history. Worth spending the last 30 seconds or so doing that, recapping quickly, checking there's nothing you've missed and you've understood everything. And then having a sensible conversation with the examiner about appropriate investigations, management plan. Few practical tips. When it does come to starting your discussion with the examiner, if they ask you to summarize things back to them, which they usually will do, be careful not to regurgitate the whole thing. They have just sat there and heard it. So they want to see your thought process and how you can tease out the important things and summarize the important things to them in a concise way. Different people have different ways of doing that. Some people like to use a problem list type approach, like you might find at the top of a clinic letter, for example. Other people prefer SR. They found that more familiar in their acute practice. Doesn't matter. Choose a system, practice it, and stick with it. It might be that a particular history actually lends itself to one more than the other, so you might find it helpful to be a little bit flexible, actually. But still worth practicing both, perhaps, and choosing one when you're starting your presentation to the examiner, and then sticking with it for that presentation at least. Again, the history needs to be focused, so important, and you can always try and anticipate some of the examiner's questions. You can even start doing that from when you're outside the room reading the vignette. You have quite a generous period of time to do that, so you can start thinking how you're going to structure your approach to the whole station and think about some of the questions that might come your way as well. Grand. It looks as though I'm still not able to write in the chat just now, Katie. Are other people having that problem as well? Just wonder if it's worth inviting some verbal questions at this time, if that is the case.
Yes, I can't type, but Bryony did manage to, so maybe some people can. But yes, please do ask if you have any. I know it's a bit scarier to speak rather than type. You all should have my email from the booking, and so if you are too shy, then you can email me afterwards as well.
You've just reminded me, actually, Bryony, I don't think I did address your question very directly, actually. So Bryony's asked in the chat there whether autistic spectrum disorder or ADHD might be possible diagnoses in the development station. I suppose the first thing to say is that the goal of the development station, as we saw there in the aims, is not to achieve a diagnosis. You're there to assess the child's development and their developmental age. So that's probably the most important thing to say. But could the child that you're assessing have features of either of those things? Yes, they definitely could. And I suppose it's worth you commenting on that if they do. And if you want to look extra good, then you'll hone your history appropriately as it becomes clear that the diagnosis might be looking like one of those things, to try and ask some more focused questions to, for example, autism or ADHD, so that you essentially are reaching the diagnosis. But clearly, to formally diagnose those things, it involves an MDT and lots of prolonged assessment, so you're not going to get quite that far, but you can show that you've got an awareness of those conditions and that you know the features and the questions to ask. Hope that answers your question, Bryony. Let me know if not.
Yes, it does. Thanks very much, Josh.
Cracking. So the communication stations, these are one of the better stations, I think, can be one of the kinder ones. Not always, they can be tricky, but they are an opportunity to do reasonably well. And one I think that's reasonably straightforward to practice, because you can do it with a colleague reasonably easily if you've got a good reference book, and we'll show you lots of available resources for all of the stations, including the communication stations towards the end. So the aims of the communication station then, to communicate appropriate, factually correct information. That's basic, isn't it? But it's important. It's very tempting, especially if we're asked a question that we don't feel completely comfortable with, to try and bluff our way through a little bit. Definitely don't do that. There will, the station I got for one of my communication stations actually was way out of the way out of my league and way out of anything that we were expected to know with regards to the specifics of the particular situation, and that's absolutely fine. I think in a way they were almost testing that people don't try and bluff and they just say, actually the question you're asking is about, in this case, a particular diagnosis that was very specialized. It was HOCM, and there were some specific questions about exercise and things. So I said, as an example, that that was not my area of specialization. I inquired as to whether they had another clinic follow-up booked, or if they had a clinical nurse specialist they might be able to contact to ask those questions to. And I think that's exactly the sort of thing that they're looking for, really. So definitely don't be afraid to just approach it as you would in real life. Communicate effectively, of course, in the emotional context of the clinical setting, and the emotional context will be pretty different from scenario to scenario, as we'll see from some of the examples. It'll usually be a role player. I think it'll always be a role player with the current virtual setup, but they could be taking various roles. They might be the parent, they might be an adolescent, they might be another health professional, they could even be a member of the public. And again, we'll explore some examples. Can include a telephone conversation. That's a little less relevant with the virtual setup, because I suppose they all feel a little bit like a telephone conversation to some extent. And the examiner is only going to sit there and observe. They don't ask any questions in this one. So it feels a little bit strange, but that's how it will be. So don't worry that you've not done anything right. The examiner's not supposed to ask any questions. Doesn't mean you can't ask them. If you have any questions about the vignette, for example, you can definitely ask for clarification. Types of scenarios, here we go. So these are the big headings that MRCPCH provide as the overall topics for scenarios you might encounter. Information giving, a reasonably common one. That could be information giving to a child or a young person about a particular diagnosis, for example, or it could be to their parent. Breaking bad news, obviously quite a different context. For example, explaining the results of a test. Consent, why there's a need to do a particular procedure. That's clearly only going to be geared towards procedures that you're expected to be comfortable with. It's not going to be anything else, of course. Critical incident is a pretty common one. For example, talking to the parent of a child who's been given the wrong drug, had a reaction to a drug, something like this. Ethics, these can be reasonably complicated, can't they? But again, about having a structured and focused approach and a little bit of background knowledge, but you don't need a huge amount. And education, again, reasonably common. For example, explaining briefly to a junior how they may deal with the situation, like a mini sort of teaching session, or some advice giving, for example. So all of these sorts of scenarios you'll find in resources which we'll point you towards later on, so it's easy to pick them out. I don't want to spend too much time going on how to approach each station, because I think really that's something you just need to practice using these resources, and they're pretty good. They have pretty detailed suggestions for the points that you need to include, and you'll go a long way using those resources. What's expected? This is all pretty basic stuff. Introduce yourself, easy to forget that, but that's important for all of the situations, for all of the stations actually. Try and maintain some degree of structure if you can, as much as anything, because it's going to help you. Having said that, if you get asked questions midway through, for example, then if you're confident enough to veer from your structure that you have in mind and answer them there and there, then do so. But equally, you could just say, if it's okay, I'll come back to that question when we've covered this. Again, try and build some rapport and use appropriate body language as best you can virtually. Pick up on verbal, non-verbal cues, again, a little more challenging, but the examiners are aware of all of this. It should be a dialogue, not a monologue. In fact, for many of the stations, I've heard lots of peers say that they end up saying almost nothing for their communication stations. That's how it feels. In a way, that's probably a sign that you've done a really good job, not a really bad job. But certainly should be a two-way conversation. Even with the information giving stations, be careful. It can be easy to turn that into a monologue, but it shouldn't be. It's better to give a smaller number of points and actually have them received than to just feel like you have to show everything you know and actually nothing ends up being taken in by the recipient. Active listening, of course. Use silence. Don't be scared to do that. Be empathetic, be sensitive, seek their concerns and address their concerns, clear and accurate explanations, jargon-free language, use of diagrams. This was relatively common, I think, back in the face-to-face days. Still can be done. A little bit more challenging. You have to hold a piece of paper up to the camera, I suppose. But if that's something that you find helpful, then that is an option. Professional respect for a colleague if it's not a parent, so the type of interaction you have with them might be a little bit different, but it's just about being your usual normal selves. Make sure you do address the task set. It will be quite focused, and check understanding at the end. There's sort of a fairly standard way you can choose to end these types of communication stations, isn't there, by checking understanding and arranging further follow-up and offering additional resources or a leaflet, for example, that might be of benefit to them. Few practical tips as ever. We've already alluded to the top one. It's not a test of the sheer amount of information you can communicate. It's really important. It's tempting to think that that is the case. It's very much not. It's a test of communication, not a test of your knowledge. You'll get warnings throughout the stations at particular times. You can find all the times that those come on the MRCPCH website. They've got a dedicated document with all of the times, which is really helpful. Worth trying to use those timings actually when you're practicing, especially when you get a bit closer to the time as well, because they will feel a bit different. So once you hear it, like we've said, there are a few key things you can do: summarize, check understanding, ask if they've got any questions, and talk about a next plan of action. Try to select the most important information, be focused, make sure it's correct, don't bluff, explain issues that are in an appropriate way and no jargon, and be emotionally appropriate and try to establish rapport and address concerns. Be nice, be normal, be friendly. You'll do absolutely fine on the communication stations.
Any questions so far?
Can I just ask, right, on the communication station, the education bit, I haven't heard about that before. Have you just got like an example or?
I could come up with an example, but I don't know if it will necessarily be an official one. So I don't necessarily want to do that because maybe that's more confusing than it is helpful. But you can certainly find examples in the resources that we'll point you towards at the end. They are out there, but it will be like a mini teaching session. You only have 9 minutes for this station, right? So it's going to be something very quick. And I suppose my top tip for any sort of teaching education type session would be to choose a way smaller amount of content to deliver than you might think, because it will be much more important to sort of show that you have a little bit of a structured approach to that and that you're inviting questions and have got time to deal with those questions. So choose a really small teaching topic, if you like, or it's probably not going to be a topic, a very small aspect of one thing, and focus on teaching that in a structured and a comprehensive way.
So I sat the exam twice, and in both times I had a teaching type scenario as one of my communication stations. So I think it is reasonably common. Lots of the sort of skills that you're using are very similar. You just have to sort of tone the language that you use to the people that you're speaking to. So like if you're trying to explain to a parent, you'd also do a similar thing in terms of like, so I had to talk to a medical student about something neonatal, and so it was about like checking what they know so far, like, you know, having a very small amount of information to try and give them, checking their understanding at the end, all of those, you know, key signposting things, rather than the detail of what you're saying necessarily, because yes, you cannot go into all of neonates in 9 minutes.
Thank you.
You introduce a medical student to your MD thesis, Katie.
Any more questions before we move on? Fab. So video station. So just a couple of points. It almost feels a bit weird to be doing a video station within an entirely video station exam, but the idea is that it's focusing on a slightly different area of our practice. So the aim is to assess the ability to make clinical observations and decisions in signs that wouldn't be easily assessed in stable children. So it's supposed to be the more acute signs in emergency departments or wherever. And then a discussion about the clinical reasoning and management based on that. So the things to think about is acute problems, respiratory distress, types of seizures. Sometimes it will be murmurs and gaits and skin rashes that could be in a different station, but it's about, I mean, it is much more similar, but you don't have to do the examination process to get that information, and it's more of a discussion based on it. And simple observations, so things like respiratory distress, grunting, seizures, discussing what you can see and what you would then do. Again, this is a lot like real life, really. That's all I've got to say on video. Basically, I'll come to it later, but YouTube is your friend for the video station, because people put videos of their children on YouTube and you can watch them. So I'm just going to go through some general tips about preparing and sitting the exam. So practice talking, because you do not normally say, I'm now going to examine blah, blah, blah. It is the bit that is most challenging, and so you just have to practice. Find a small group, stick with them, meet regularly, and now that it is virtual, you can do it virtually, meet on Teams and just make each other work. Be honest with yourself and your group. Don't just say that you're good when you're not. You have to push each other, and make all of your seniors teach you. This is not the time to be polite. Well, polite, but these people are have all had to use their own seniors before. They've all had to do the exam, they know, and they can teach you. And using people you are scared of will make you better and make you prepared for presenting in front of people you don't know. You've got to just commit to it for now, but do also give yourself some time in between. Don't burn out before you get there. Use your study leave. I don't know if the rules are the same everywhere, but definitely in London you are allowed to take a couple of days of study leave prior to an exam. Seeing real children is debatable. From people who sat it the last couple of times, I think they've still found touring the wards in a COVID-safe manner and going to clinics useful, because that's just how you see the breadth of those syndromes and signs that you wouldn't necessarily see otherwise. But it is a very different, you have to also do the practicing of how you explain the examination, because they're very different skills. And think about those emergencies and signs and rarer things. Time yourself and stick to it. Do all of these examinations, whether it's on real children or whether you're on Teams under exam conditions. They have all of the mark sheets on the website, and so you can use them as you're doing it, test and test each other properly. practice your presenting and the discussion of the cases particularly, and have your patter down. I'm very bad at saying and so you just need to make sure that you pick up on the things that you're bad about. I speak very fast, and when I get nervous, I speak faster, and I wave my hands a lot, and so just recognize what you do that is ridiculous and stop it. Organising revision sessions and mocks can be useful, and lots of hospitals and deaneries do arrange their own things, so you see what's around. Don't forget the small print examinations, so Snellen charts, MSK, thyroid, anything can and does come up. So you don't, you can sort of predict the things that are more likely to come up for sure, but just don't forget about them. Don't forget about the communications and history. It's really easy to just think about the clinical examination ones, but remember to practice these ones. I've said in the book, I'll show you in a minute which book I mean. And familiarise yourself with equipment, particularly for the development station, where you are already provided with what it is that you will be using, but also just think about what else you would be using, like Snellen charts or whatever, to do your examination. And yes, use the mark sheets. Pre-exam tips: make sure you check all of your IT, and you will get a lot of emails. You think I'm being silly, but this is how many emails you receive, plus others, reminders and things. You will need all of these different emails for the different things that you have to log in on the day, so just try and keep them all together so you're organised. Remove all of your children and pets and things, lock them out. You have to have your ID card and your admission document to show to the camera. You can have water with you, and you can be smart casually dressed, but just, the same as you would for anything, but comfortable within your virtual environment. In terms of IT, just remember about checking your internet as well, and optimise where you are for the best internet available. In terms of the exam itself, you are being watched doing what you do every day. Just do it. Do it with confidence. That was definitely, I think, one of the things that made a difference between the time that I failed and the time that I passed, was partly about really thinking, I am the registrar, I can do this. You have to get into that mindset to be able to. You can have pencil and paper and take notes during the reading time and in the station. And if a station goes wrong, there's always something that you just can't quite get what they're trying to get you to say. Just forget it and move on. Often when something goes wrong, it's the next station when you're still worrying about it that things can then spiral. So try and just move onwards and upwards. Don't make up signs. That is definitely going to be picked up on. It's harder to do that now that it's virtual and they show you things, but still possible. Remember that the examiners do sometimes get it wrong. They are doing their best and want you to pass, but if you think that something hasn't worked or they've not heard you or something's happened, raise it on the same day, because it's much easier to fix things or note that there's been issues on the day rather than a couple of weeks down the line. And there's a Slack channel as one of the many emails that you get that you need to you use to communicate. If you get thrown out of Praktik Oski or something else happens, then you can speak in there. And then forget about it. So you can not think about exams for another couple of weeks before you get those results. One other thing I forgot to add into this slide was we are all more and more familiar with the virtual setting, but just to think about what you're doing and how you're presenting and how you adapt your communication styles whilst you're online. I am not so good, but the things to think about is making sure that your camera is not, pointing up your nose, making sure that you are looking at the camera rather than at the person, so that they think that you are looking at you. You could even have your dog to help things look nicer, like this person has. Don't do that. But it is now what we have to do in order to have these communication. If it goes wrong, the world will not collapse. Lots of people didn't pass first time, like myself. One of our old consultants passed 7th time. They are a wonderful consultant. And revising really does make you better. All of the exams that you've done in your life, it is the one that is most clinically relevant, that will make you learn things that you will then see and will help you in the future. Sometimes it is just luck and things just don't work out for you, but sometimes you can see that something went wrong and don't do it again. You will get all of your mark schemes and they should have useful feedback and advice in. Previously, people used to say that if you were borderline, like just a few marks below the pass mark, that you should consider a remark. Since the changes to the system just prior to COVID, it's not quite the same. So it's less likely that a remark will help, because the way that the marking system works, it should stop people failing inappropriately earlier on by being more fair. And they have also increased the price of paying for a remark because they feel that it's not so appropriate anymore. But, to consider. These are the main resources that we used. So in terms of books, this is the communication scenarios book. There's this, if you do all of the ones in this, that is all of the communications sorted. This is really good as an overall, all of the different short cases, particularly for the clinical stations. But lots of these, bear in mind, are 4 different formats of the exam previously. Circuits for the MRCPCH is very old, but was really useful. It just has sort of mock circuits of all sorts of scenarios, and it was of a format many times before the one that I sat, but I still found it useful. Do think about reading the curriculum, because it is the point of the exam is to make sure that you've met the curriculum standards. So have a read through it, because that's what the questions are based on. Another one from the same set, survival guide. So lots of sort of clinical information standardized and summarized. Some people swear by this one. I didn't find it so helpful, but for the development station, I found that it went into a lot more detail than you needed, but some people found it useful. So have a look, get it from a library first. This is the website that we talked about, where the summary of the development station came from. Again, it is based on previous forms of the exam, but there's lots of videos of people doing different scenarios, which are helpful just to see how different people do things. RCPCH website, as we mentioned, that's this one, the London School of Paediatrics YouTube channel. So this recording will be on there, but there's also lots of videos about different topics, which are definitely relevant for your exam, so have a look. YouTube generally, so yes, watch people's children walk and talk and do different things. And there's lots of guidelines and things that are useful to think about, particularly for when you're doing your communication, your sort of explanation type things. GOSH has some really good like lay language explanation leaflets, which I found really helpful when you're trying to explain these quite complex diagnoses. RCPCH, NICE, SIGN, all of those guidelines for preterm counselling, Nuffield bioethics, Epicure and BAPM are useful to just have a think about. And then generally in terms of your sort of knowledge base, there's lots of podcasts like Peds Pods and Dragon Bites that are worth a look. Courses wise is the other thing. Lots of them sort of haven't restarted since COVID because of the challenges of getting lots of children in one place, but some places are doing mock exams like GOSH, so do have a look at what's around. Some of them are better than others, but as long as you're, you can use them as practice anyway, and just familiarising yourself with the format and with the things that can come up is useful. So that's it. A sort of whistle-stop tour of the exam and a summary of the different stations. It's definitely, basically, you're going to be all right. It is what you're doing. You just have to believe that you can do it and practice. Any questions? Smashing.
Please do shoot if anyone has any questions, guys. I'm sure many people have, so don't be shy. If your chat's working, by all means pop them there. I've tried to make this notes thing and put my email address in there. I don't know if people are able to see that, but if that's worked, very welcome to email me. It's Josh, JOSH_Hodgson, HODGSON @live.co.uk. Sounds like these.
So this recording will go up on the YouTube channel in the next couple of days if anyone didn't manage to make it. And yes, you also have my email from booking, so do email me as well. Someone looks like they're typing. Perhaps. Oh, someone has their hand up. Hello. Fiber.
Oh, hi there. I'm Vaibhav. I'm one of the ST4s in cases. I had a question. Do we still apply for remarking? My last attempt, I got 64, unfortunately, and I did email the team, and they said we cannot apply for a remark. It's some modified Enghoff scoring method now.
Oh, fine. If that's what they say, then yes, they had definitely the last time I spoke to them about it, they had said that you could still get remarks, but you wouldn't. The chances of it being successful were so small that it wasn't really worth it anyway. But you are right. Since it's become virtual, they're using a different scoring system to get the marks. So perhaps it isn't. Yes.
Okay. Thank you so much.
There's a question on the chat. If you want to do if you're asked to do a cardiovascular exam and you want to do a general exam first, or do you do the general then the cardiovascular, or combine both? I mean, when you're doing a cardiovascular exam, it wouldn't just be listening to the heart. You're doing your sort of starting at the hands, working your way up, looking at the face, moving down. So I suppose that is your general exam, unless there was anything particular you meant. And then you would always be sort of finishing with mentioning the other bits of the exam that you would be thinking about doing. So listening to the lung bases, etc. What have I answered your question?
And you don't necessarily need to be super structured and stick to a very traditional structure. It may well be that you want to include other things in your examination that maybe wouldn't fall under a very strict definition of a CVS examination, for example, and that's absolutely fine. That may well be even the right thing to do in a particular scenario. And they can always remember they can chuck really weird and wonderful things at you. Probably not so much these days when it's virtual, I guess, because it would just be even trickier to handle. But you can be asked to, like examine a leg or something that you've probably never even thought about before. And like I was asked to examine a big leg, basically. So you can get weird things that you've never come across or probably never even thought about before. You just have to sort of think on your feet and think a little bit sensibly. So I don't say that to scare you guys. I don't think that's very common, and it's probably less and less common. But what I do use it to say is to demonstrate that you definitely do have a bit of freedom to approach the examination in the way that you wish and include extra things if you think they're going to be helpful or relevant. That's probably the right thing to do rather than the wrong thing. And
of course, if the examiner doesn't want that, they will tell you. So if they think you're going off on the wrong track, they will get you back on track.
And if you're not sure and you're worried about starting down a rabbit hole, you can ask them.
Yeah. Any more? Smashing. All right. Oh no. That's just someone arriving. Lovely. Thank you for coming. I hope it was useful. Sorry the chat didn't work. So if you have been unable to ask your questions, then just let one of us know and we will do our best. And good luck.
All the best, guys. You'll all do great.